Hi, everyone. Welcome to Community Cares and Project Echo Screening and Prevention Series. Today's session is on HIV and cancer. Thank you for attending today's session. As a reminder, please keep your microphones muted during the presentation. Enter all questions into the chat box. We'll do a Q&A portion at the end. And we are recording today's webinar. If you would also kindly introduce yourself in the chat, tell us your name, your organization, the areas that you serve. So this is just a quick disclaimer that the information contained in this presentation is not substitute for medical consultation. A physician should always be consulted for any health problem or medical condition. So this is today's agenda. We're going to do a Project Echo series overview, introductions, factual presentation, a case study, and then at the end we'll do questions and answers. So, a little bit about Project Echo. Project Echo is a movement to demonopolize knowledge and amplify local capacity to provide best practice care for underserved people all over the world. The Echo model is committed to addressing the needs of the most vulnerable populations by equipping communities with the right knowledge at the right place at the right time. So, for more information on Project Echo, you can visit echo.unm.edu. So, we're going to start with introductions. This is Sid. Sid is the prep counselor for the Robert Wood Johnson AIDS program at Rutgers Robert Wood Johnson Medical School and a member of the New Jersey HIV Planning Group. They specialize in individual and group education around HIV prevention and related topics, especially those related to biomedical HIV prevention, such as PrEP, which stands for pre-exposure prophylaxis. They prioritize working through a trauma-informed, culturally aware, interdisciplinary lens to end the HIV epidemic, addressing social determinants of health from patient to provider to population. Sid is also passionate about HIV history and ensuring equitable access to information and care for all. So, Sid, I'll hand it over to you.
All right. Thank you so much for that great introduction, Sarah. Yes, my name is Sid. I work with the Rutgers Robert Johnson AIDS program at Robert Johnson Medical School in New Jersey. And today we're going to be getting a little bit into talking about HIV and cancer and the way that the two of them interact. And we're going to start actually a bit talking about the history of HIV and cancer because they have a long-standing historical relationship. That's me. We already said most of that stuff. I'm a certified health education specialist. I got my degrees from Rutgers, etc. You see what I look like. Next slide. So, just a little bit about where we're at today with the HIV epidemic. So, we still are seeing new HIV cases. We still are seeing HIV transmission. It's not nearly as high as it was in the mid 80s. In mid 80s, we were seeing over 100,000 new cases annually. Now, in 2022, which because of data lag is around where we're getting current data, the US had an estimated 31,800 new HIV diagnoses. And a lot of these diagnoses are made up of cases where someone involved did not know their HIV status. They didn't know they had HIV and therefore weren't in treatment. And part of why it's so important to get people in treatment, not only to delay and even halt disease progression in people with HIV, it's still not curable, but it is very, very treatable, is because people who are getting effective treatment can potentially get to a point where their viral load is undetectable on a blood test. And if they are undetectable, they cannot transmit it to another person sexually. It has to be maintained. If they stop taking their meds, their viral load will go back up. But when someone has a lower viral load, they're less likely to transmit it to other people, and they're less likely to have significant health impacts for themselves, which is especially relevant for today's discussion. Next slide. So this was the first public article on HIV, rare cancer seen in 41 homosexuals. Some of you might have seen this article or have heard of it. It is from the New York Times, based off of a morbidity and mortality weekly report and reports from a doctor in New York that were discussing Kaposi sarcoma, which was or is, I should say, a type of cancer most commonly found as a skin cancer. And this form was particularly aggressive, with eight people known to have died within 2 years. And one notable thing is the first line of it, and then cutting a little bit later, that cancer is not believed to be contagious, but conditions that might precipitate it, such as particular viruses or environmental factors, might account for an outbreak among a single group. So the search for cancer-causing viruses really shaped the early research into HIV. HIV's original name was actually human T lymphotropic virus 3, coming after the first two human T lymphotropic viruses that were found to cause lymphoma. The viral theory of cancer was really just kind of exiting the public consciousness in terms of research at that point, and this kind of brought things back. And the other thing that also really paralleled what they were seeing with early AIDS progression was actually FeLV, feline leukemia virus. So that gave early researchers an idea into what might be causing these outbreaks of Kaposi sarcoma, because we were seeing them in clusters, but we didn't think cancer was necessarily contagious. We later found out that KS is not caused by HIV, it's caused by herpes virus 8. Um, and I'll mention that a little bit more later. But this article led to the first colloquial, and sometimes even in research circles, term for AIDS, which was gay cancer. The next official term was GRID, gay related immune disorder, and then finally AIDS. But gay cancer stuck around for quite a bit, which, again, colloquially, officially, it was gone within a couple of years. But the stigma of both still really stands. Next slide. So the first person to publicly come out with an AIDS diagnosis, or wasn't called AIDS yet, but this aggressive form of Kaposi sarcoma, was a public health nurse named Bobby Campbell from San Francisco. And he would kind of shepherd people who were diagnosed where he worked to this group called the Shanty Project, which was for, at the time, people with cancer, people who had terminal cancer and shifted into a gay cancer support group. And I like these quotes because they really give an insight into the mindset of where things were at that time. So Dan Turner was a friend of Bobby Campbell, saying, who's been quoted saying, "I remember thinking in the back of my mind, well, some people beat cancer, maybe I will. Cancer was the worst thing anybody could say to you before AIDS. And I told myself that's what I had, cancer. And the stories of people getting over cancer were a little core of hope." And even now, like we talk about, like, colloquially, "Oh, I don't want to touch that. That's AIDS, that's cancer." Like, we still use those terms as like a way to show disgust or not wanting to associate with something. And it's just also like so heartbreaking to think of someone wanting their diagnosis to be cancer so that it could give them hope, right? And then on the other side, you had Bobby Campbell, who was very, very out there, very passionately putting up posters of himself with his lesions from KS on display for folks to see. He called himself the KS poster boy and later the AIDS poster boy. And he said, the purpose of a poster boy is to raise interest and money in a particular cause, and I have aspirations of doing that regarding gay cancer. I'm writing because I have a determination to live. You do too, don't you? So, just a little snapshot into what things were like back then. And nowadays, we have significantly improved outcomes, which I will mention. As we go through. But one thing that is especially notable is that the relationship between HIV and cancer has actually led to the first people being cured of HIV. So I mentioned that there's no cure for HIV. That's only mostly true. There have been 7 people who have been found to be completely cured of HIV, and they were all individuals who got bone marrow transplants as a result of lymphoma or leukemia. And not everyone who gets a bone marrow transplant will be able to cure their HIV, but in these cases, some of them had donations from someone who had a gene mutation that resists HIV, some didn't. But those are the cases in which we've seen someone's body be able to completely clear HIV for the first time. It's not, excuse me, it's not a practical option for everyone with HIV, but it is encouraging and fascinating that we have seen that happen. Next slide. So I'm going to briefly touch on co-screening, and why we're talking about these in tandem. Um, you know, it's also going to show up in our case study, but really we want to limit the burden on patients, on clients as much as possible, right? Because every time that we have to make them another appointment, make them another referral, that's additional time that they have to take off school and work. That's an additional time that they have to maybe find childcare, that they are spending more money doing insurance claims. There's a risk and a break for continuity of care with every additional visit. So getting as much done as possible and condensing as much knowledge into one location as we can really helps improve outcomes a lot. We also know that there are common and overlapping risk factors for HIV and certain kinds of cancers. Patients may not know their risk profile. And while it's great that people with HIV are living longer, that also means that we're starting to see more people living with HIV getting age-related cancers. So we'll get a little bit into that in a second, but you'll see the acronym that's at the bottom, PLWH. That's just people living with HIV. Next slide. So again, data lag, a lot of the studies that are out there vary wildly on what some of the rates for different cancers look like. This is from 2019, and it's on the more recent end of data I can find. It's not like anything happened in 2020 or later that messes with healthcare data or anything like that, so I'm sure that it's completely fine. But the highlighted ones are ones that have a higher proportion in in people living with HIV than the general population. The ones that have the little green arrows, the rates of those cancers have gone down, and in the time period listed from 2010 to 2019, and the ones with red dots have a statistically significant p-value. And at the bottom, you can see that the AIDS-defining cancers pretty much all have gone down significantly. There's still significantly higher rates than in the general population, but we're seeing a really, really encouraging trend in rates of things like non-Hodgkin's lymphoma and Kaposi sarcoma. But we also are seeing rates going slightly up in some of these kinds of cancers, or staying level with non-significant p-values for things like oral cancer. And these rates, for how much more prevalent they are in people living with HIV, you can see some of them are as high as vulvar cancer being over 11 times more likely, anal cancer being 17 times more likely. And so essentially, the rates overall of people living with HIV getting cancer are declining because of the AIDS defining cancers, and the non-AIDS defining cancers are remaining more stable and expected to increase over time. When I say AIDS-defining cancers, those are specifically cancers that are included in the CDC's list of AIDS-defining illnesses. So they are illnesses that signal that someone's immune system is really at a point that it can't handle fighting off infections effectively. It's one of the ways to define staging for HIV, as well as CD4 count. Next slide. So, why is this happening? There's a lot of reasons, but one of them is comorbidities and opportunistic infections. The biggest one probably is HPV. HPV is responsible for up to 99% of cervical cancer cases. And in recent years, we've also started recognizing that it causes a whole host of other cancers, from penile, anal, oropharyngeal, vaginal, and vulvar cancers. Cervical cancer is also particularly notable because you might have noticed on the last slide, it said AIDS defining when invasive. That wasn't the case until 1993 was when it was added to the CDC's list of AIDS-defining illnesses. So even though it was a major killer of women living with HIV at the time, people who had, say, cervical cancer but not Kaposi sarcoma couldn't necessarily get disability benefits or other things that other people with AIDS could get depending on what diagnoses they had. Um, I also wanted to mention that the 3-dose Gardasil regimen is recommended for people living with HIV over the 2-dose regimen. Gardasil in general, still highly recommended. And cervical cancer is also one of the ones that we really haven't seen a decrease in rates for. We're still seeing very high rates of cervical cancer in people living with HIV. HPV and HCV, the hepatitises, they cause over a third of global cases of liver cancer. They're highly comorbid with HIV. And even if liver cancer is not caused by that, if it's caused by something like alcohol consumption, hepatitis can cause cirrhosis and accelerate progression of liver cancer. KSHV is herpes virus 8. Kaposi sarcoma is herpes virus. One of those things that most people will run into and most people will have no issues with. Epstein-Barr virus is one that there's emerging evidence that it might be linked to a few different lymphomas and is also more prevalent in people living with HIV. Cytomegalovirus is another AIDS-defining illness that does not cause cancer but can accelerate progression. And in general, people living with HIV, taking medications, etc., while they can get to a better outcome when they are undetectable, when they've taken their medication consistently and can have long, healthy lives comparable to someone not living with HIV, it's still a chronic illness that can lead to significant inflammation and immune function isn't fully restored. Next slide. So, what does it actually look like when people with HIV have cancer, right? So, again, two different studies, but when people with HIV get into care, they are, well, let me back up. When they're diagnosed, they are more likely to be diagnosed later and they are less likely to be maintained in care. So on the left is from the HIV/AIDS cancer match study, and it found that people living with HIV were less likely to be in care for several kinds of cancers, most notably, again, cervical cancer. And this is just a binary yes or no in care. It says nothing about the quality of care. And we know that people living with HIV oftentimes have limited access to healthcare and related resources as well. Um, and then on the right is cancers that, one, if they're bolded, they're ones that had a later stage in diagnosis, so more likely to be diagnosed in stage 3 or 4. And for all of the types of cancers looked at, whether or not they were diagnosed later, for all of them except stomach cancer, they had a higher mortality rate for people living with HIV. So, for example, lung cancer, even if they were diagnosed at the same time, people living with HIV were still 20% more likely to die from lung cancer than people not living with HIV. Cervical cancer, 1.85 times. Next slide. So, screening considerations for the HPV related cancers. Cer most of them, I see there's a hand. We're gonna do questions at the end, or if you want to pop in the chat. So for most types of cancer, the recommendations are the same. Um, and taking into account other risk factors for things like lung cancer, doing low dose CT scans if someone has a history of smoking, etc. The ones that the recommendations diverge is HPV related. And so, cervical cancer, there is an additional recommendation for co-testing, 3 consecutive co-testing every year for people living with HIV, and then every 3 years. There is now home HPV testing available, which is great. Um, and the rates of screening, though, vary a lot by study. So a study on home HPV testing found that people were less likely to get tested for cervical cancer, and then other studies found that people were more likely to get tested for cervical cancer when they had HIV. And a lot of that is because of where those studies are based. So if someone has HIV, they may be more likely to be maintained in regular medical care. However, that skews the results because if a study is done in a healthcare setting where people are already getting healthcare, we're not accounting for the people living with HIV who aren't getting any healthcare, HIV related or otherwise. There's a little snapshot just from the Robert Johnson slicer dicer of where our population is at in regards to their cervical cancer screening. And you can see that for people living with HIV, they are less likely to be overdue on their cancer screening by EPICS metrics. But again, that's tilted, that's biased because these are people who are already in care, right? And then for anal cancer screening, there are a few different approaches and consensuses on anal cancer screening for people living with HIV and MSM, men who have sex with men, including anal pap, which is probably becoming the most talked about, well known, anoscopy and or digital anorectal exam. That's usually what folks start with. There is not one consensus on anal pap. There are some different organizations and professional bodies that have put out recommendations, but there's no solid national or international one. And the most recommended when there's abnormal findings is high resolution anoscopy, which is very poorly accessible. Less than 5% of people living with HIV are estimated to have access to that. And those who do have access to it have reported really negative experiences. We've had at least two people who were referred to colorectal surgery for anorectal exams and endoscopy, got a high resolution endoscopy, and reported bleeding that night and the next morning, pain, and refused to go back for additional screening, right? So even though it might be a quote unquote better option, if the patient's not going to do it, if it's going to lead to them not getting screened again, it's really not the better option, right? Next slide. Yeah, so these are the current recommendations for um, people living with HIV from the NIH to get their anal cancer screening. Again, looking at if a high resolution anoscopy is available, basically do it if it's high res, don't do it at high res if you only have access to regular. But essentially starting with collecting specimens, performing digital anorectal exams, and then if there's any symptoms or abnormalities, going into HRA. Um, again, it's an emerging area in terms of cytology, recommendations, etc. But it's definitely something that is being looked at very closely as a result. And we know that Gardasil can help prevent anal cancer as well as cervical cancer. So recommending that for people who are at risk as well. Next slide. Um, so when we're talking about all of these factors, right, and my arrows are gone now. I added more arrows to the slide because I felt like it was missing slide. Felt like it was missing arrows, but all of these underlying factors that contribute to HIV, cancer, et cetera, they all interact, right? And so a lot of these are they're not things that cause HIV in a lot of cases, right? Like living in poverty doesn't cause HIV, but we know statistically there are disparities. It makes people more susceptible to HIV. It makes people more likely to get HIV depending on things like socioeconomic status, and things like socioeconomic status, location also affect access to quality health care, which then affects their likelihood of getting HIV if they're not able to get treated, if the people around them aren't able to get treated, if they're not able to get PrEP, if they're not able to get cancer treatment and screening. You see where I'm going with this, right? So it's a cycle. And we also know that a lot of those behavioral and lifestyle factors as well, things like smoking and alcohol use, can um, can also, sorry, drop something, can also have an impact on cancer rates and HIV rates. So, alcohol, for example, impaired decision making, leading to people being less likely to use condoms, more likely to engage in risky sexual behaviors, more likely to contract not only HIV, but also HPV. And again, alcohol alone, major cause of liver cancer, right? So we can see how these all end up interacting. And also that we know that people with higher stress levels, higher minority stress, et cetera, might be more likely to use alcohol excessively, et cetera, or to a harmful degree, not even just excessively. So all of these interact in a way that I do not have time to do justice to, but just keeping in mind that there's so much going on behind the scenes in every single patient that can lead to them being at risk for HIV and or cancer. Next slide. Great. Case study time. All right. So our case study, um, our patient is female, 26, and she has perinatally acquired HIV. So it was passed from her mother to her. Her mother did not take her medication consistently, and she also did not give it to the patient consistently. She was told not to tell medical professionals when she wasn't taking her medication, which is a habit she carried into adulthood. The mother, because she really wasn't, treating her HIV effectively, she had both cervical and colorectal cancer, along with other complications, and she did not understand the severity of the disease. At one point, when she got diagnosed with cancer, she said to her case manager, "The doctor fixed me up before, they can fix me up again." She did not pass away of cancer, but she did pass away of HIV-related cryptococcal meningitis. Our patient was diagnosed with non-Hodgkin's Burkitt lymphoma as a child, date unknown, but she is in remission and she is connected with or was, I don't know if she's actively connected with them, but has been connected with the LIGHT program for pediatric cancer survivors at Rutgers Cancer Institute. She was sexually active early. She got pregnant for the first time at 17. And the care management team had a had difficulty finding a provider who was willing to do a pap smear for her because she was not 21, despite the fact that clearly she was sexually active. There was a risk for HPV. She had HIV. They got a provider who was willing to do her first pap at age 18 and already showed low-grade cancer cells. Subsequent screens that she's gotten have shifted between high and low-grade precancerous cells. She was supposed to get a LEAP and was hospitalized for HIV related pneumonia, which she gets hospitalized a couple times a year for. And they could not schedule the LEAP until she got cardiac clearance. And so our case manager had to call cardiac, get that appointment set up. She would no show appointments for cardiac, etc. And then when she finally did get clearance for cardiac in November, cardiac did not communicate that with GYN. So her LEAP didn't get scheduled until it was supposed to be Monday and the patient canceled. It is hopefully rescheduled for today. So very active case study. Um, when she does get hospitalized, she regularly leaves the hospital against medical advice. She can be difficult to contact. She has a high history of no-shows that makes it difficult to get clinics to schedule her. She's unable to adhere to oral treatment regimens. She's now on injectable HIV treatment, Cabenuva, which is every 2 months, which has now gotten her to an undetectable point, which is fantastic. But her health is very much not out of the woods yet. She still regularly gets very sick. Um, and she has had multiple sexual partners, no known condom use, history of gonorrhea. Again, she would mention that she was taking her meds. She would not be forthcoming about that. She would not be forthcoming necessarily about her activities sexually. The first time she came in with gonorrhea, she said she got it from a toilet seat. Um, and when she would come in saying that she was taking her meds and then her viral load would come back in labs through the roof, the doctors would run all of this resistance testing to try to find out what was going on. It would all come back normal. And then she would, be a little more forthcoming about like, yeah, I wasn't taking my meds. Right. So a lot of folks would look at this and see a non-compliant patient or a difficult patient, someone who is not engaged on their own care and doesn't want to be. But there's a lot more going on under the surface here. Next slide. So this patient is the primary caretaker for both her son and her niece because her sister is unable to care for them. Her primary support is her grandmother because her mother passed away and wasn't a strong support. And in her life before then, her grandmother mostly raised her. She's on dialysis. The grandma's on dialysis now. The patient has difficulty with comprehension. And so a lot of these important concepts for understanding your HIV care are things that she really struggles with. There are incomplete records from her getting care at multiple locations. The EMRs have helped with that significantly, and Care Everywhere has helped significantly, but she still sometimes goes places that are not in the Care Everywhere agreement. She's unable to work consistently and relies on a partner who also is unable to work consistently, and as a result, has pretty unstable housing, has been unhoused quite a few times. She doesn't have any alcohol or drug use, but because of the fact that she gets sick so frequently, it can be hard for her to hold down a consistent job. And because she has no support for things like childcare, she can't stay in the hospital, which is why she keeps ending up leaving AMA because she has to get back to her kids. She has to get back to trying to make money, etc. But she has come a really long way. And that's thanks to really intensive case management, really heavy lifting by her case manager. Co-located services, the thing that finally got her to start getting repeat PAPs, because after that first one, it was very, very difficult to get her to get another one, is that we now have a GYN clinic located within the hospital outpatient clinic area that we are in. So she's able to, within the same day, get her, have her appointment with her provider for her HIV care, go to the pharmacy, and go to the lab and go to GYN. So that helps immensely because that could have been 4 different trips, right? The injectable HIV treatment, as I said, that's what finally got her to be undetectable. The HIV injectables for both prevention and treatment are an absolute game changer. And she's also been maturing a lot, right? And that's just something that we see in folks who have perinatal HIV or pediatric cancer, for example, that as they grow up and they start to get a better handle on themselves and their illnesses, etc., that they're able to handle and process it, right? Next slide. So this is just something I threw in there, and we'll talk more about the case study because I definitely want to see if people have questions and thoughts as well. But this is something that we use in the field of HIV prevention and care called the status neutral care model. And it's something that I think is a great model for any types of preventable or screenable disease or disorder, which is that when someone is positive, obviously we get them into HIV treatment as soon as possible. But when someone is negative, we still support them with methods to stay negative, such as condom use counseling and pre-exposure prophylaxis. And the same can go for cancer, right? Like if someone comes back and gets a lung screening and they are a smoker, you're not just going to send them off and be like, okay, come get your next screening in a year, right? Ideally, you're going to talk to them about smoking cessation. You're going to talk to them about their goals and their barriers to smoking cessation, the underlying factors that are leading to them smoking and maybe having difficulty quitting, or if they want to quit, if they're ready to quit, et cetera. So I think that no matter what outcome someone has for any kind of screening, that making sure that they're getting that follow up and that it's being done in a way that is beneficial and accessible to the patient is really, really important. Because again, thinking back to the case study, if we're telling her to come get HPV screenings annually or every 3 years, and she can't make that many appointments, she's not going to get them done, right? So we really have to support the patients and meet them where they're at. Next slide. So this is a brief overview of our staff. If you are one of the local folks, you can feel free to reach out to us. If you're not one of the local folks, thank you for being here. And you can also reach out to us, but I'm not sure how beneficial we would be if you're in West Virginia. I think I saw someone was from. But we really do try to practice the medical home model. We provide as much wraparound care as we can, especially for our pediatric patients living with HIV. A little bit about who we are and what we do. Um, and being part of the Rutgers Health System means that we are able to very easily make referrals, have co-located services, etc. Next slide. And that's just contact info for our program. Again, if you're local or if you're not local and you want to reach out. Um, but yeah, so that is what I have got to start. And I definitely want to hear y'all's thoughts and questions, get into the case study a little bit, go from there.
First
I'm
off,
look.
thank you so much, Sid. I do know we have some questions, so I'll let
Mhm.
Evelyn
We
read
have
them.
a question. Could you please explain a little more about the perinatal acquired HIV of the patient's case?
Yes. So for context, I am also 26, so I was not here when that transmission happened. Um, and a lot of staff who worked with her and her mother, they were both clients, are some have retired, left the program, etc. But again, her mother was not active in taking care of herself and her own care. She was not taking her HIV medication. This was also in 1999, so we did have a lot of advances in HIV treatment by this point, but we didn't have daily pills like Biktarvy or injectable options like Cabenuva. And when someone has uncontrolled HIV, when they have a higher viral load, it makes perinatal transmission significantly more likely. There are a lot of things we can do to mitigate perinatal HIV, and it's been all but eliminated in a lot of places in a lot of circumstances. We still do see it very, very rarely here. Um, but really the key thing there is if we have someone who has HIV and is pregnant or wants to get pregnant, that they need to be able to have the support to take care of themselves and their own health care to help avoid passing it on. And then if they do pass it on, making sure that they're able to get the support themselves and then give the support to their child who has HIV. Because, of course, if you have an infant or a child with HIV, you're responsible for giving them their medication. You're responsible for keeping track of all of that. And if that's not something you can or want to do, that's not going to lead to great outcomes for the patient. I see there's one more in the chat, but there's a hand up. So, hand first.
Yeah, let's go with the hand up first.
I can't hear you. Um,
It was Sophie's. You can unmute if you would like and ask your question.
Sulfise is unmuted. They might be having a problem with their sound.
Yeah, if you could maybe just put it in the chat, just because I can't hear you.
While they're putting that question in the chat, I
Yeah,
have another one. How does PrEP work in preventing people from getting HIV?
great. That is a question that I can answer. So as I mentioned at the beginning, I'm the prep counselor. So the way that we have a few different types of prep now, and someone stop me because I will otherwise just talk about prep for the rest of the time. But we have four different types now. Truvada was the first one that we had. Descovy came after is the other oral, and then we have two injectables, Apretude and Cabenuva. Or no, sorry, Apretude and Yeztugo. Cabenuva's treatment. And the Apretude is the 2 month injectable. It is intramuscular, and Yeztugo is a 6 month subcutaneous injection. So only twice a year. And they all work a little bit differently. Um, the most groundbreaking one has been lenacapavir, which is Yeztugo, which is a capsid inhibitor and is also highly, highly effective against treatment-resistant HIV, which is fantastic. Um, I am not going to pretend I know enough about microbiology to get into all of the nitty-gritty about how the different forms of PrEP work. But essentially helping to stop replication. So HIV is, and I have some about my notes on this actually that I can go back to. So HIV is what's called a retrovirus, and they are viruses that convert their own RNA-based genetic material into DNA using reverse transcriptase. So a lot of HIV treatments and prevention are fall into the class of what's called INSTI, or uh, spotlight video. Oh, I got a little pop-up. I was like, I don't know what that is. Um, so they use reverse transcriptase and essentially hijack the body's own immune system to make more of itself, replacing the host's DNA with their own, which is why we see the death of things like T cells, because instead of making antibodies to protect against, um, you know, when you still do get HIV antibodies, but your body is not able to effectively fight off HIV on its own because when HIV infects a T cell, it forces it to replicate again and again and again and again until the T cell dies and releases millions of more HIV into the body. So PrEP works by interrupting that process. If it's an INSTI-based medication or whether for prevention or treatment, it stops that transcriptase it stops that transcriptase inhibitor. INSTI stands for two different things as well. We also have a rapid test called INSTI. And so I never remember the acronym because in my head I just hear INSTI and I think the test. So I apologize for that. Um, but yeah, the short, not super scientific answer is that it helps to stop replication. Even in people who aren't on PrEP, an encounter with HIV doesn't 100% mean they will get it. Um, we know that things like higher viral loads are more likely to lead to transmission, but that, our bodies still can potentially, help us out. And PrEP helps our body in doing that, is kind of how I explain it to patients. Um, I hope that helps. I know that was a little all over the place. I failed chemistry in college, and that's why I did not go and end up going into molecular biology, which was my original plan, but I'm much happier here. So I will
I
go
I
back to the
think
chat.
I think it was a great answer. I understood it. I hope other people understood it. And I'm not a science background either, so hopefully that was well. So I do have the question that I'm sorry, is it Sulfisi? I don't know if I'm just pronouncing your name correctly, but it's a multi-part question. So
Yeah, I see.
what were
Mhm.
some resources provided to that patient? Did they have a social worker reaching out? Was there a navigator? To verify the best way that they can support and ensure
Mhm.
that she fully understood her diagnosis.
Yeah. So again, I don't know much about the patient's parent situation, right? Um, our program does provide case management, social work, psychological support, etc. We are fully wraparound services, and I can say that for both the mother by the end of her life, or even by the time she had her daughter, um, that she was, fully supported by our program. And we are part of what's called the Family Centered Care Network for HIV care and treatment in New Jersey. So we're one of only a few places in the state that is equipped to handle perinatal and pediatric HIV exposure and acquisition. And we are a very, very dedicated program. At the same time, if someone does not see the importance of being engaged in their care, we can only do so much, right? And our staff, they go above and beyond. They really do. And there's also a limit to what we can do, right? So for the daughter, like I said, she's made great strides since she's been, part of the program her whole life. And she has navigation and support and, everything from trying to make sure she has transportation is something we can support with, getting grocery cards, um, lots of other things. I know there's a couple people on my team in the audience if anyone wants to throw in other things that we have on the care and treatment side. Um, but it's really intense navigation and education as well. And unfortunately, sometimes that's still not enough. And, in this case, because of having perinatally acquired HIV at such and it was so uncontrolled from such a young age. She's had cognition issues since she was pretty young as well that make it difficult for her to comprehend. And, you know, with her mother not giving her her meds and really instilling in her this idea that, you know, she has to lie to her doctors and say that she's not taking her medication. She has to make the doctors think that she's doing what she's supposed to. It really set her up for a difficult place for her relationship with the medical system, which is something that we is not terribly uncommon in care and treatment or in prevention. We have a lot of people who have either individualized or systemic trauma with the medical system, but at the same time, as much as we wish that we could give everyone housing, food, shelter, universal basic income, it's not something that we as a society are structured to do. We are supposed to have housing for everyone living with HIV under a program called HOPWA. It is significantly underfunded, and we have a housing shortage in New Jersey for people living with HIV. And so, it's not a case of throwing everything at the wall and seeing what sticks. It's very tailored, it's very targeted. And also, this is a case of a lot of the societal structures being a major part of why the outcomes are so poor here and why she's having such difficulty because, you know, we as a program can't provide childcare. We can provide support and resources, but what do you do when the FQHCs, when the childcare centers, when the the housing for people living with HIV, what do you do when all of that's full? Like there's this idea that all of these resources that do exist and do great, amazing, wonderful work, that they all are, able to take in everyone, and that's just not the case, especially in the current climate, where we are seeing support for things like SNAP benefits, EBT, you know, FQHC's research, all of this being slashed, is it's getting more and more difficult. And yes, the patients are under the care of a clinical team. Yes, the doctors, the infectious disease doctors are part of our team. We work very closely with them, and then as well, we have good relationships across departments. Very much a benefit of being part of a large medical system is we can just message people on Epic or also just walk down the hall sometimes, depending on where or what specialty. Um, so a little bit of a soapbox there. But I hope that it helps a little bit of that. She does have her caseworker that she checks in with regularly. Her caseworker watches to see, like, you know, is she able to get to her appointments? If she canceled or no showed, like why? Like following up with all of that. And it really is like a significant heavy lift. And obviously that's not her only patient. We have a lot of patients. Um, yeah. Anyone
I don't see
else?
any other questions. Sarah, did you get any questions?
I did have a question. I know Janet kind of asked earlier, but I just wanted to, I guess, just clarify because I'm just curious. So, when you're on prep or when you're on medicine and it becomes undetected, the
Mhm.
HIV, can you still pass it perinatally?
No. So generally no. So just to be clear, PrEP, you won't become undetectable on PrEP because PrEP is only for people who don't have HIV. Undetectable is if you have HIV and your viral load is so low that when you go to get your viral load testing, it's less than 20 copies per milliliter of blood. Um, but PrEP, there's overlap in the medications used for PrEP and treatment, but they are considered two different regimens. Like even Yeztugo is the exact same medication as Sunlenca, which is the treatment for um, resistant HIV. And they're two different medications with two different billing codes and all of this awful insurance stuff that I have to deal with as a PrEP counselor. But in Epic, they both come up as lenacapavir, which is a nightmare for me. But I'm going to leave that to the side. But if someone has HIV and is undetectable, it is extremely unlikely that they will transmit perinatally. Even perinatally, most transmission does not happen in utero. Most transmission happens at birth or even through breastfeeding. So there are a lot of things that we can do to mitigate the risk of perinatal transmission, even if the mother is not on treatment. And I don't know where the patient in our case study was born, if it was here, if it was somewhere else, et cetera. Um, but let's say that patient gets tested third trimester and it's positive. There can be things like elective cesarean sections or essentially post-exposure medication for the infant that can help to mitigate that risk. But obviously, if someone is undetectable on their medication, that helps significantly. They might still elect to do a cesarean section or other mitigation factors, and there are now guidelines changing on people being able to breastfeed when they're undetectable. It's sort of up in the air. Again, it's different orgs have different recommendations. Some say yes, still some firmly say no. Um, but luckily, perinatal transmission is something that we are seeing far, far, far less of now.
So, Sid, I have kind of like an aha moment.
Hmm.
So basically, if somebody's taking their medications, they're undetectable, they have a partner, long-term partner, partner's on PrEP, pretty much that partner is protected against
Yes.
HIV. So that's
Hmm.
fantastic. That is, you know, a huge, huge, just it's miraculous when, growing up, like it was huge when I was a freshman in high school. This was all just starting to come out and really be an issue. And I'll never forget the health teacher was basically like, when they were doing the sex ed stuff, it was if you have AIDS, you're dead. That's it. She's like, that's all the information we have because it was like
Yeah.
such early days. So like coming from that to this, it is just amazing and really miraculous. So,
Y-
just I'm always in awe of that.
Yeah, I
So
mean, you're right on the money. Like there's no reason that anyone, I mean, ever need to get HIV, but that anyone needs to get HIV. Um, we have biomedical options like different options of PrEP. We also have post-exposure prophylaxis that can be started within 72 hours. And people who are in a what's called a serodiscordant couple, one person has HIV, one person doesn't, we still recommend that the person who does not have HIV go on PrEP just as backup. But as long as someone's undetectable, since they can't transmit it sexually, there are people who rely on the fact that their partner is undetectable to not transmit it, and it works. I recommend PrEP, regardless of partner status, as something that anyone can do to keep themselves safe, no matter what their partner or partners are doing, as an aside. But same with if someone has HIV, if they stop taking their medication, et cetera, that viral load goes back up very quickly. And there actually is a term for that modality where we know that undetectable pretty much eliminates the risk of sexual transmission and lower viral loads decrease it, is called TASP, or treatment as prevention, right? Because if we are lowering the amount of people in a community who are able to transmit HIV, that does just as much heavy lifting as making sure the people in the community are protecting themselves from HIV, right?
what about insurance? I know we haven't really touched upon that, but how is the insurance industry
It
either
is,
creating barriers or helping with this?
I don't think insurance companies have ever helped with anything. Um, but Yes. So insurance companies for both PrEP and care and treatment. For care and treatment, it can be a bit difficult to get specialized medications, things like Cabenuva, et cetera. They'll want to do things like step therapy and want to try cheaper generic medications first. And that can be a process. And that's another thing that our case managers handle a lot of, and on the PrEP end, I handle a lot of. So PrEP, technically, under the Affordable Care Act, is supposed to be covered. All insurances are supposed to cover PrEP with no cost sharing. A lot of insurances interpret that as covering one form of PrEP. And then there's a lot of heavy lifting that we have to do if they want, say, the injectable. The injectable has gotten easier, but there are a lot of nuances with how to obtain, especially the injectable. Um, I have had insurances that just outright would not cover any form of PrEP. And it's like, even though they're supposed to, like, we're not really going to be able to fight that, right? So finding alternatives, I work with the pharmaceutical companies to get free or discounted medication for PrEP patients. You know, I have regular contact with some of the people from pharmaceutical companies about where things are at with different insurance companies, with different specialty pharmacies, how that acquisition looks. Um, and, we do have a lot of patients who are uninsured who need PrEP or treatment, and the pharmaceutical companies do support that as well, which is great. They also are supposed to be covered by Medicare and Medicaid. And you might have heard the term Ryan White funding before, which is named for a young man who acquired HIV when he was in middle school through infected blood products and unfortunately passed away at the age of 18, but did a lot of wonderful advocacy work for HIV in his short life. And Ryan White funding is the biggest payer besides insurances of HIV related care, biggest public payer. And that's because it helps with both medical care. If someone is uninsured or underinsured, that can help significantly. And it also helps a lot of those ancillary funds for things like grocery cards and transportation as well. Um, but insurance never makes things easy. Um, I have spent an inordinate amount of time dealing with trying to get injectable medication just because the billing process for that specifically for it used to be also for Cabenuva, but that has gotten easier, is convoluted to say the least. And it's unfortunate, to say the least, because no one should have to die of AIDS. No one should have to be getting AIDS-defining illnesses. None of this needs to be happening.
Thank you so much for the entire presentation, for answering all of our questions. I knew we were going to have a lot of questions because I didn't really know much about this, and I had a bunch of questions while reading the presentation. So thank you. We really appreciate you taking your time to do this.
Yeah,
I
thank you so
just
much for having me.
hopefully we'll have you again soon. I'm going to share my screen again just to share some links real quick. So this is NJ Seed. They do early detection. They have screening programs. They do breast, cervical, colorectal, prostate. The phone number and the link will be in the chat. Thank you for attending today's session. Please use the link in the chat or this QR code to let us know how we did. We really do look at all the evaluations, so thank you for filling it out. I'll go back to that, but I think I have. Oh, yeah. So this will all be posted onto Mighty Networks, which is kind of like our Canva platform. We post all the recordings as well as any resources that Sid is going to share. We're going to post it. And I know we kind of touched upon cervical cancer and HPV. We also have two other sessions that we did. We did a infectious agents session and we did a gynecological cancer session that covered both of them. So that's all in Mighty Networks as well if you wanted to learn more. And please feel free to post any events that you have coming up on Mighty Networks. And then join us in March for a session on ovarian cancer. Thank you all for attending. I'm going to go back to the evaluation. Thank you. Thank you, Sid.
Thank you all for having me. I also put my email in the chat as well. Excuse me. I'm also in the Mighty Networks thing as well, so you can find me there. And yes, please fill out the evaluation because I would like to know how I did and how I can improve as well.